Prajna Venkatesh to give this lecture. Dr. Prajna, again, everybody knows in the field of cornea, has won accolades for his research and his work. He is the academic director of Arvind Eye Care System. He oversees the residency program in Arvind Eye Care hospitals, manages the training program, has numerous peer-reviewed publications in leading international and national journals, and also the chief editor for Payments, Principle and Practice of Ophthalmology, the second edition that compiles the contributions of more than 300 contributors. He is also the editor-in-chief of DigiNerve and has figured in the top 2% of the scientists in the field of ophthalmology, selected by the Stanford University, and he is going to be talking about advances in diagnosis of infectious keratitis. So, Dr. Prajna.
Can I have my slides, please? Thank you very much, Dr. Namrata and the AIOS for giving me this Endowment Award. I'm especially thankful that it is named, I'm giving this talk which is named after Dr. G.N. Rao, who has seen me from my school days, and it is indeed a great honor for me to be speaking in this talk. So I'm not able to see anything here. Should I use that podium? Thank you very much. Yes. There's no conflict of interest in this specific presentation. At the outset, I would like to pay my respects to a visionary par excellence, a person who brought research into ophthalmology in our country, a great institution builder, and a dynamic leader who exudes professionalism. As I mentioned, Dr. Rao knows me from my school days, if not my college days, and I would like to personally acknowledge a few of the personal instances. Whenever Dr. G.N. Rao is around, I'm very, very careful with how I dress. At least 3 or 4 times in my career, in the American meetings, he used to come and adjust my tie, and that has still not caught up with me, and so I decided not to wear a tie today. I knew that sir would be in the podium. The second thing, he always tells me, don't use the word sir, and I'm not able to get away from that. I continue to use it. But jokes apart, when I first finished my residency, and I was actually immediately following my residency, I got an NIH project which was involving 3,400 patients. I did not know the nuances of randomization and all that other stuff. And there was an international DSMC group which was actually set up, and Dr. Rao was a member in that. And he hand-held me in my earliest career of entry into research into ophthalmology. Thank you very much, sir, for what you have done for me personally and also mentored me professionally. So these are my, I've been interested in infectious keratitis for quite some time now, and this has been our research contributions in the field of infectious keratitis in the past 30 years, focused very specifically on infectious keratitis and all aspects provided with infectious keratitis. And this is the basic research stuff also where we have contributed in this field, making us the single largest contributor in this field of infectious keratitis globally. Today actually I thought I will just share two of my papers, one which was published in AIOS2020 and the other very fresh off the press in December 2023 in JAMA Ophthalmology as the topic for this day. So actually these papers talk about two different things. One is on smart probes, and I'll be talking to you what I mean by smart probes to diagnose corneal infections. And the second thing is how to use a device to actually rapidly diagnose aspergillus keratitis. Before actually I go into the topic, I want you to see this slide. This is a in fact, this will maybe the most important slide in my presentation. I'll be coming back to this slide at the end of my presentation, but just register this slide in your mind and I'll come back to this slide later in my presentation. So I talked about the smart probe and its use in infectious keratitis. The first lesson I learned in research was to go beyond your area of comfort. And it was very difficult for me when you have already contributed enough. Then I was actually scouting for what else can I do in this field of infectious keratitis. And I thought, okay, the cornea gets infected with fungus, the lungs get infected with fungus, why don't we explore working with the pulmonologists? So then I actually ventured out and then I found out that fluorescence, the whole concept of fluorescence imaging has revolutionized the identification of tubercle bacilli. And we thought, okay, let us see whether that can be applied so that we can use it in ocular microbiology to make life simpler for us ophthalmologists. So we worked with University of Edinburgh. They have an excellent laboratory, nothing to do with ophthalmology. There were no ophthalmologists around there. But then we started working with the pulmonologists there. And we did what we proudly refer as cross-learning. And what they were actually using it, to be very frank, before I even went to talk with them, when they were saying about probes, I thought they were talking about surgical probes. Then only after I talked with them, I understood what they were meaning was chemical probes. The probes which will go and actually find out the organism for us. So there were actually essentially two chemicals, one which is BAC1 and the other is BAC2. When you actually mix the BAC1, it goes and identifies gram-positive bacteria and fungus in the lungs, and BAC2, which will go and identify the gram-negative bacteria in the lungs. And what they use is they use a bronchoscope, go and spray this BAC things into the lungs and directly image, and as you can see, you can directly see the microorganisms from the lungs directly by the clinicians. So I thought maybe this is a technology which is worth exploring, and what we decided initially was, can we apply the same technology for corneal ulcer? Cornea is in a much simpler place than the lungs, not ensconced or not hiding behind a rib cage. So I thought, let us try this out as a fashion. And we published the results of this in American Journal in 2020. And this is actually a very simple step. It just talks about all the fluorescence and other things, gives a hype around it. But it's actually a much more simpler thing. No sample fixing is required, no wash steps is required. And then the microorganisms come and talk to you. Here I am. You know, you don't need to be searching for them. They come out very, very openly. And what we did was, in this study, as you know, gram stain is the gold standard, and we compared the sensitivity and specificity, the positive predictive value and the negative predictive value of gram stain with, first for BAC1. I said BAC1 is used for identifying gram positive and fungus. And then, as you can see, the negative predictive value, the positive predictive value is much better than a gram stain. See, for gram-negative, it's even better. Gram-negative probes are even better, so that these actually chemical probes can go and identify and make life easier for us to identify these organisms. So we made a statement that smart probes were equivalent or better than gram stain at matching gold standard culture results. Now, this is not the end of the story. What we are actually now developing is whether the smart probes can identify the inflammatory markers like IL-17 and C3 and C6 and other activation. And so we will get a much more detailed information than what we are getting now. So this was the publication which we published in 2020 in the American Journal of Ophthalmology. That was the first topic which I wanted to highlight today. The second talk, which got published in December 2023, around 4 months back, was again to see whether something simpler can be used to diagnose aspergillus keratitis. The whole thought process is, what if we bypass the whole culture system? See, at this point of time, we have to do a culture to identify whether it is caused by bacteria or fungus. Is there a way where we can bypass the whole culture method and get the finding of the organism in 30 minutes? As you know, a culture of a fungal organism takes 4 to 5 days, and for it to speciate, you need a specialized laboratory. Whether we can use an LFD device to find out whether that organism is caused by aspergillus directly, because as you know, the mud study where I was the PI very clearly told that different fungi respond to different antifungal drugs. So that's the point to see whether we can bypass the whole thing. So how does this work? So from the corneal ulcer, you can either do a swab or a scrape and just put it in a aliquot and then use a reader. And then if you can see the black bands. If you see that band, then it is positive for aspergillus, because we are specifically looking for whether it is caused by aspergillus or not. If it is negative, it is not caused by aspergillus. But then you completely bypass the culture mechanism. You don't require a very sophisticated laboratory, and you don't require a completely dedicated microbiology system. What did we do? The lung people had already done this, but what did we do is we identified what is called as a ratiometric analysis tool, where we actually quantified it and expressed it in a map to see, as you can see, the spikes in the positive thing is an equal spike between the control and the positive. So very clearly it is a positive map, while the second and the third thing, as you can see, second is slightly better than the third, but the third is definitely negative. So that was the whole thing, and then what we said was the sensitivity is definitely equivalent to culture. And by ratio analysis, we are able to say that the positive predictive value and the negative predictive value is much better. So what it means is, it can detect an organism directly, not going through 2 steps of smear and culture. And also, because if we can get it diagnosed correctly, then it may help with patient satisfaction and treatment. And also, directly there is an opportunity for taking this, especially when you just require a swab, you can actually take it to the field and keep it at a primary care level. What we are now doing we are trying to make separate LFDs. LFDs are there right now only for aspergillus, but we are designing new LFDs for fusarium, and also we want to actually design a comprehensive LFD which can identify all organisms, and at one shot we may probably know whether it's caused by fusarium or aspergillus. So this was the publication which we published last year in JAMA Ophthalmology, and this is the rapid point of care identification of aspergillus species. So what do we know? Where are we now with regard to ocular microbiology and corneal infection? We all know that as clinicians, it is almost impossible to identify whether the ulcer is caused by bacteria or fungus when the ulcer is in an advanced condition. In the earlier condition, you can definitely do it, but in an advanced condition, it is by chance. So we also know that qualified ophthalmic microbiology personnel are not enough in our country, and dedicated ocular microbiology, and then there's a lot of difference if you just use a systemic microbiology lab and an ocular microbiology lab. So dedicated ocular microbiology labs are also very few. This is what we know. And how do we get information as of now? As of now, in the good microbiology labs, even when you have dedicated ocular microbiology facility, you get, this is the finding you get from an ulcer of this kind. But what we are envisaging, we have repurposed actually a technique which does not require a seasoned ocular microbiologist. We also have now repurposed a technique which was used in the field of pulmonology, which can bypass the culture technique and its associated requirements. And we believe that in the near future, this is the sort of report we are going to get when we are going to get a microbiology report. Not only we will have an information about the infecting organism, but we will also know that there is a heightened IL-17 activity, there is a high increased C3 activity, there is also an increased MMP5 activity. Now we are completely starting a new era in the way how we will be able to give information to the clinician. This is something like a topography. Before the topography came into place, what we actually knew was whether the cornea was steeper or flatter. That was the only thing which we were interested, and the only slit lamp and the keratometer were the only things which were giving us that kind of a report. But now, with the advent of topography, we are able to get so much of information from the same cornea. So is there a way to have this? And we believe the smart probes, which can identify the microorganisms, if you design it well, it can also be able to identify the inflammatory markers. And our colleagues in the pulmonology whom I have worked, they've also found out that topical matrix metalloproteinase inhibitors can be applied to the lung. And they did not actually proceed with that because topically you cannot apply in the lung, but we also know that topically you can apply in the cornea. So there is a possibility that we will be using a lot of inflammatory, anti-inflammatory drugs along with the anti-infective drugs when we actually treat corneal ulcers. I come back to this original slide, which I said is the most important of my slide. So previously when you did not know cooking, you were at a loss. Previously, either you have to take your mother or your wife wherever you had to go. Whether you like them or not, you have to be dependent on them. Now you don't. Now you have so much of choices. You don't need to know cooking, but you have all the dishes on your table. Zomato brings it to you. Amazon, take Amazon. Amazon doesn't have a shop by itself. But then there is an agency which will be able to get what you want in your hand. So that we want to actually push the whole thing, the power to the ophthalmologist to completely bypass the laboratory techniques. How Amazon did it, how Uber did it, how Zomato did it, that's what we want to replicate in this whole exercise. So I want to end by once again reminding Dr. Rao, he might have forgotten, 25 years back when we were in Chicago in an American Academy meeting, we were in a Jackson lecture together. And when we came out of that lecture, Dr. Rao remarked, how I wish that Indian ophthalmologists come and deliver named lectures like this in an international forum. Sir, the day is not far off. I just want to reassure you that whatever you said on those days is still ringing very, very deeply in our minds. And those kind of inspirational talks or inspirations which you have given to us will hopefully stand good in the future days to come. Thank you very much for your patient hearing.
Thank you, Dr. Prajna.